Hello, everyone, and welcome to the third installment of the Fellow Lecture Series. My name is Adrian Dan, and on behalf of the ASMBS and my co-moderator, Dr. Kunoor Jain-Spangler, as well as the West Coast moderators, Dr. Judy, Chen, and Dr. Matt Martin, I'd like to welcome everyone. I want to take a couple minutes to remind everybody about the goals of this project. This is a monthly lecture series, which is designed with our bariatric surgery fellows in mind. It is also designed to fulfill the curriculum learning objective requirements of the ASMBS for certification, as well as for the fellowships to obtain Fellowship Council accreditation for didactics. We are very lucky today to have a couple wonderful speakers that are going to speak to and lecture to us about the role of endoscopy for the bariatric surgeon. I want to start by saying that both of the speakers today are innovators and leaders in metabolic and bariatric surgery. And I will start by introducing Dr. Leena Khaitan. Dr. Khaitan is currently the director of the Metabolic and Bariatric Nutrition Center, as well as the Swallowing and Esophageal Center at University Hospital Case Western Reserve Hospital. She also has the distinction of being the first female full professor of surgery at that institution. Dr. Bipan Chen has a similar role. He is director of bariatric and minimally invasive surgery, as well as a lot of other administrative roles at Loyola University in Chicago. Both of our speakers have extensive publications, peer-reviewed papers, textbook chapters, and are leaders in formalizing endoscopic education for our specialty, both in SAGES and in the ASMBS. So without further ado, I want to go ahead and proceed with our lecture this morning, and we were going to start with Dr. Leena Khaitan. Leena, take it from here.
Well, thank you so much, Adrian, for that kind introduction, and it's really exciting to be a part of this series. Really, congratulations to you and Kunoor for putting this together. What a great opportunity for the fellows, and I'm going to go ahead and share my screen here. Weird. Okay, here we go. I always enjoy doing these courses. I wish I could be with all the fellows because I always enjoy meeting them. But hopefully I'll get to meet you all at some place and sometime, hopefully next year when we can physically be in the same location. So today we're going to talk to you about endoscopy in the bariatric patients. And I'm going to start with talking about pre-op, intra-op, and kind of recognizing anatomy, and then primary bariatric procedures that are done endoscopically. And then Dr. Chen is going to talk about dealing with complications endoscopically. And honestly, the use of the endoscope has really changed how we're able to do things in bariatrics. For many of us, like Dr. Chen and myself, we've used endoscopy throughout our practices, and using them in bariatrics, I would say, has become more popular over the last 5 or 6 years. And now I would say it should be a normal thing in the operating room and always be there. So I'm going to start first with preoperative endoscopy, and we'll talk a little bit about anesthesia considerations and some of the and then we'll talk about some of these other topics as we go through the morning here. So anesthesia, of course, is very important because our patients are big, right? The majority of them do have sleep apnea. Many of them have pulmonary hypertension and increased restrictive airway disease. So it's really important that we pay attention to that, particularly when we're doing a lot of these procedures, most of them under conscious sedation. And in fact, many of the procedures now, I usually do them with anesthesia, and it's really important to have good airway protection. Unfortunately, you hear once a year, every other year through the grapevine that a patient had an apneic event and died during an endoscopy. And it's just a thing that should never happen as long as you're taking the appropriate precautions ahead of time. So airway protection is very important, and having anesthesia available when you're doing your scopes is helpful. I usually use conscious sedation and have them there. Always know, it's helpful to know the patient's sleep apnea status, but basically you should just assume that they all have sleep apnea. These patients generally require more sedation just because they have more adiposity where they can store the medications. But there are studies showing that if an anesthesia provider is present, that the patients tend to have less of a sore throat, less gagging, better sedation, and fewer cardiopulmonary events. So preoperative assessment in bariatric surgery. So this is a very, very controversial topic, but I myself use preoperative endoscopy routinely. I think it's very important, and these are the many reasons. First of all, it allows us to look at many things. If you think about it in surgery, there are very few procedures we do where we don't evaluate an organ prior to altering it in some way. And in bariatric surgery, we're altering the foregut anatomy, and if you've never looked at it, you might not know what you're going to get into, and I'll share some data with you shortly. But these are some of the different things that we can look for, and for me, H. pylori and Barrett's are two big ones, particularly as we're doing so many sleeves. You can take biopsies as needed, and every once in a while you might find some masses that you're not expecting. In our experience, we find something at least 40 to 50% of the time, and our surgery is altered about 5% of the time. And to me, that's a lot. A lot of people say, well, it's only altered 5% of the time, and so that's not very much. Why do you need to do it? That means you're doing 95 endoscopies unnecessarily. So there's a lot of discussion in this area, but I can tell you I've never regretted doing a preoperative endoscopy. And particularly understanding reflux in bariatric surgery, I think one of the other important parameters, other than finding some pathology, is also looking at my patient's Hill grade. And the Hill grade is the retroflex view of the cardia that you get, and this helps you assess hiatal hernias. And if you think about it, there's two aspects to the hiatal hernia. One is the vertical excursion of the stomach into the chest, and then the other is the opening in the diaphragm. And so when you're looking antegrade and you see some gastric folds above the hiatus, that's your vertical excursion, but the Hill grade allows you to better assess the opening in the diaphragm, and that may be a more important parameter for our bariatric patients. This is something that we're actually reviewing in our practice right now. And I want to share with you a study from one of our leaders here, Dr. Dan, that they just recently published. And there's a lot of research out there on this, but their research happens to be in line with what I believe. And they looked at 1,000 patients. And of those 1,000, only 48 patients had no findings at all. So that means pretty much everybody, 950 patients, had something. Now, a lot of those things were not necessarily clinically significant in that they had some gastritis or gastric polyps, but almost half of them had something that needed some sort of treatment or intervention, including hiatal hernia, esophagitis, Barrett's, and particularly if you have a patient with straight up Barrett's and you're planning to do a sleeve, you might rethink that direction in terms of the procedure you're going to do. So like I said, there's a lot of data out there, but this is a wonderful paper that Adrian and his group just published. So read it if you have a chance. Now, intraoperatively, we're going to switch to that. I use endoscopy, like I said, at every single case. I do my leak test with the endoscope. So I place after I complete my procedure, then I'm going to place the scope. And it's also a great opportunity for the fellows to hone their endoscopy skills as well. And not only can I do my leak test, which technically you could do with an NG tube or with methylene blue, but this also allows me to look for bleeding, because you can have bleeding on those staple lines, and you can manage that right away rather than finding out about it in recovery or the next day. Also, it helps, it's helpful for me to know that my anastomosis is open. I do a circular staple anastomosis, but for those of you who are doing hand sewn or whatever, it's another way to look at it to make sure it looks the way you want it to look. And when I'm doing this in my sleeves, you know, I'm again confirming that I don't have any narrowing at my incisura. I actually measure my distance from the pylorus both externally, but I can really see it endoscopically where my staple line starts, so that I know that I've started that staple line at a good spot, and I'm going to make sure that there's no retained fundus or hiatal hernia that I left untouched. So intraoperative endoscopy is extremely helpful. So now I'd like to switch to recognizing postoperative anatomy. And I think this is something that all the fellows need to be able to recognize an alteration in foregut anatomy. And wherever you are going to practice, if you're going to work with GI, you want to educate your GIs also on this anatomy and what you're looking at, and what they educate them on what they're looking at, so that you can accurately assess your patient. Because let's be honest, when we all do our procedures, everybody's got like a little spin on how they do their procedures. So every gastric bypass is not the same, for example. It can be anti-colic, it can be anti-gastric, retrocolic, retrogastric, and then your anastomoses can be made in different ways. They can be hand sewn, they can be a linear staple, a circular staple with a 25 or with a 21. And the stomach, there are even people out there who had undivided gastric bypasses. So there's a lot of variations, and knowing all these different variations and being able to recognize the anatomy and then what your findings mean in context of the variations and the various ways your anastomoses are made will help you better manage the patient if they're having a problem. So and when you're assessing a post-operative patient who had a gastric bypass, these are the things that you want to make sure that you're documenting in your notes. So you want to note the pouch size, where the EG junction is, and where the pouch outlet is. You also want to make note of a hiatal hernia and where that diaphragm pinches, if there is a hiatal hernia. You want to note the size of the pouch. Is it dilated? You want to note the size of the gastrojejunectomy, or the site of the gastrojejunectomy, as well as the size of the opening. Whether the patient has that elusive candy cane, and I'll be happy to talk to you guys about that if you want to later, but that's definitely a point of discussion. That's that little overhang of the small intestine when you make your anastomosis, and it's the blind end of small bowel. And when that gets dilated, that can cause some pathology and symptoms for the patient. And then you also want to look for bile in your rhulim, because essentially there should not be any bile in your rhulim, and that might clue you into the fact that maybe there's a distal obstruction. So these are just some endoscopic pics of a patient who had a gastric bypass. And so if we look at some of these different pictures, you can see there's kind of an outpouching of the gastric folds here. So this patient does have a little hiatal hernia. And then this over here is the blind end. So this is the candy cane, so to speak, and this is the rhulim. So when I'm looking at the gastrojejunectomy, I like to see which is the primary outlet, like what's straight down. Is it the candy cane or is it the rhulim? Because that can help with explaining some symptoms. And then if your pouch is big enough, it's nice to do a retroflexion, but sometimes it can be too small to do so. So make sure you make an intraoperative judgment. And then Dr. Chen is going to talk about all these other reasons you may want to scope after a gastric bypass, and then how you might manage them. As we all know, gastroesophageal reflux disease is becoming a bigger issue in bariatric surgery. We kind of used to have the conversation like, well, you have reflux, but you know what? You lost your weight, so the reflux doesn't matter so much. But now we know it definitely does matter for our patients. And so these are just some of the various things that might cause some of the gastroesophageal reflux. And these are some of the things that you might want to look for as well on your endoscopy. Gastric bands, a lot of these patients are still out there. So it's important to know what gastric band anatomy looks like. Again, you're going to look at your the base of the esophagus. You're going to mark where your band is. And then you want to do a retroflex view. And this is what you want to see. You just want to see the band in place and not much else. This is what you don't want to see. If you see an erosion like this, that's a problem. And fortunately, we do have some tools to take care of this endoscopically, and I think Dr. Chen will be talking about that later. The gastric sleeve is the other procedure where you want to know the postoperative anatomy. So when you're looking at your sleeve anatomy, this is the stuff that you want to make sure is documented in every note. Does your patient have a hiatal hernia? Is there any dilation of the fundus? Is there any angulation or narrowing at the incisura or any other areas in the sleeve that might cause some dysphagia, reflux, or pain? And then I like to retroflex not only in the proximal portion of the sleeve to look for hiatal hernias, but also in the distal portion of the sleeve so that you can look at the incisura. And if it's very tight to the scope, then that might key you into that incisura being a little on the tight side or having a narrowing or angulation there. So this patient, for example, has a hiatal hernia. We're looking down the sleeve and it looks pretty reasonable. And then this is our retroflexion distal to the incisura. And you can see that I could see all the way up the sleeve, which actually, if you can see that far, it might be a little bit on the dilated side, but these are the different things you want to pay attention to. And then I thought I would just mention VBG because there are still people running around there who've had a VBG, and oftentimes the anatomy is misinterpreted so that this retroflex view, when you see this portion of fundus going up, is interpreted to be a paraesophageal hernia when in fact it's the divided portion of the fundus lateral to the pouch. And you might also see mesh erosion or strictures at the outlet of the pouch. So those are some key things to look at. And now I'll switch gears to primary bariatric procedures done endoscopically. So we have all sorts of things in this arena. We have implantables in the form of balloons and liners. We have endoscopic suturing at our disposal, ablations, and aspiration. And I'll talk about each of these individually. So the intragastric balloon is basically a space filler that's placed within the stomach, and it's inflated to the size of a grapefruit, generally with anywhere from 550 to 700 cc's of saline. It depends on the device that you're using. And basically it makes the patient feel more full because their stomach's already filled with something. And it initially causes a little bit of hyper motility in the stomach where it's trying to push the balloon out. And then essentially the stomach gives up, and then you develop some gastroparesis for the remainder of the time that the balloon is in place. The nice thing about this procedure is that there is no permanent change to the anatomy. The patients have a very short recovery time, although the nausea that they experience within the first 7 days can be extremely difficult to manage. So it's important to get on top of that before it even starts. And so we start our antiemetics the night before the procedure. And then the downside of this is that this is temporary. Essentially, you're only going to have that restriction for the time that the balloon's in place. And as you can imagine, your body would not want something like this to be in place forever. And so the balloon that we have FDA approved here in the United States, those balloons are only allowed to be in for 6 months at a time. And then they do require a procedure for insertion and removal. And probably the hardest thing for us to deal with is it's not covered by insurance. The most commonly used balloon is the Orbera. And I've placed a good number of these, and my patients have all lost 30 to 50 pounds. And then I've had a couple people who even had it placed after taking a holiday, placed it twice. And it actually works really, really well for a lot of my patients. And then what they do is they get 12 months of ongoing dietitian counseling and intensive monitoring to make sure that they can maintain the habits that they developed in terms of their eating for the 6 months after the balloon's removed. The Obalon is another balloon system that's FDA approved, and I'm not going to discuss the Reshape because it's been removed from the market, but these are the 3 FDA approved ones. The Obalon is an air-filled balloon, and this balloon is actually placed in the office. So the patient swallows a little capsule at the end of a string, and it's blown up in the office. And because the balloons are placed sequentially, one every couple of weeks, the amount of nausea that the patient has with this procedure is significantly less than the Orbera. Although they do have some The air-filled balloons do not seem to have as much weight loss as the fluid-filled balloons, but we have one of our family practice docs placing this here in our system, and it just really hasn't taken off. So we really do more Orberas. The transoral sleeve gastroplasty is another endoscopic procedure that is gaining popularity. So we have this beautiful device, and we use sutures to collapse the stomach to mimic the lumen of a sleeve. So we place 2 rows of sutures, and they can be placed in several patterns, and the people who train you on them will go through these different patterns with you, and it basically mimics a vertical sleeve gastroplasty. And so you can see that the lumen of a stomach that normally looks like this, immediately after the sutures are placed, looks like this, and then 3 months later actually looks like it's still there. So it has some reasonable durability. There's some decent data out there. This is just one of the longer term studies out to 24 months showing that at least 84% of the patients per protocol had greater than 10% total body weight loss at the 2-year mark. But I think there's still more research that needs to be done here. I think, you know, definitely it's been shown that this is feasible. It's also been shown to be reasonably safe. The expense, again, it's hard to get the same insurance coverage for this like you would for a surgical sleeve gastroplasty, although that has been a mechanism people have used. Otherwise, this costs at our place around $14,000. I think the question is going to be durability, but I know we have a lot of discussions about durability of the sleeve in general, so I think there's a lot of things to discuss there. For me, the biggest concern with this procedure is the fasteners that are used to hold those sutures is going to make it difficult for me to staple across that stomach if I want to do a future procedure. And so that's where I worry if it will preclude future surgical operations. Aspiration therapy is another FDA-approved device, and basically this is a peg, and the patients aspirate 30% of their meals, and it's very important they practice mindful eating so that carbs will not empty really through this tube, but meats and vegetables will. And I know there's kind of an ick factor with this, but if you look at the data, and one of the studies that was done here in the United States was the Pathway trial, at 1 year, patients had 37% excess weight loss compared to 13% who had lifestyle counseling only. And then if we look at the European registry, they have 4 years of data showing 19% total weight loss that's maintained. So I think the data is actually pretty reasonable. But finding the right patient, I think, is hard. We've been offering it, but we haven't actually done one yet at our institution. But the patients do have reasonable weight loss. It is removable, so it doesn't prevent any future therapy. So this technology does show some possible promise. The transpyloric shuttle is another FDA-approved device, and it blocks the gastric outlet. And their endobesity trial showed great efficacy. Unfortunately, I think it's not commercially available at this time. The company is waiting to be bought out. I think they ran out of money. Now, there are a lot of developing technologies out there, and I'm going to talk fast so I don't take Dr. Chan's time, and I'll touch on them briefly. The Allurian, or the ellipse balloon, is just like the Orbera, but the key thing about this, it does not require any procedure for insertion or removal. So this opens up the people who can put this in. A nurse practitioner could put this in their practice. It really doesn't have to be a surgeon or a proceduralist of any kind. So I think this is going to be a real game changer when it comes to market, and it's going to be very repeatable. And that the patient has it in, the valve dissolves, they pass it in their stools a few months later, and then they could put in another one. And because it doesn't require procedures, the price point, even if it's cash pay, won't be as high as the other balloons. So I think that this is going to be a very exciting technology when it comes to market. The Schwartz balloon can stay in for 12 months as opposed to 6 months for the FDA approved ones because it is adjustable, and it's not available here in the United States yet, but is another balloon that's out there. And then let's talk about the liners here. So there are 2 liners out there. One is the Valentex that starts at the esophagus and goes well into the small intestine. And the other is the endobarrier that starts at the duodenum and goes into the small intestine. And the idea is that you're basically bypassing any absorption, and these are considered malabsorptive procedures. The endobarrier had to be pulled from the market, as we saw a lot of liver abscesses in the trial, although it did show great effectiveness, particularly in improving diabetes. It's back in trials again, so it'll be interesting to see when these actually come to market. The Valentex is also in human trials in Toronto and Mexico, and hopefully we'll be able to offer that as well soon. And then magnamoses. These are little magnets that are placed endoscopically and can create connections between different parts of intestine. And so this is also going to be an exciting technology. Just a few humans have been done thus far, but it's not ready for prime time. So when you're doing endoscopy in your patients, consider an anesthesia provider. Important to know your anatomy, and these primary weight loss procedures are really going to fill the gap, and there's a lot on the horizon. So thank you very much, and I appreciate your attention.
That was fantastic, Leena. As we transition over to Dr. Chan's portion of the presentation, I want to discuss a couple reminders. First of all, I just want to remind everyone that our lecture series is broadcast at 7 a.m. Eastern Time, and also at 3 p.m. Eastern, noon Pacific Time, at which time the West Coast moderators will also have a Q&A session. Each of the two sessions will have a rebroadcast, but also their own Q&A session. And there's a Q&A function to the Zoom application, which we encourage all our attendees to use. We will review the questions and choose the ones that are most appropriate for the lectures and relevant. With that being said, I want to transition over to our next speaker, Dr. Bipan Chen. I do want to say that the whole essence of this lecture series is to ensure that fellows everywhere, not just in the United States, but across the world, can benefit from outstanding lectures like the one we just witnessed with Dr. Khaitan, and benefit from the knowledge and experience of leaders in our specialty. And with that being said, I'll tell you that I've benefited from having access to Bipan for a whole year as his fellow, about 15 years ago when neither of us needed readers. But without further ado, I'm excited to introduce Dr. Chen, who's been one of my mentors and always will be. So Bipan, without further ado, take it from here.
Great. Good morning, everybody. I want to thank ASMBS and both Adrian and Kunoor for inviting me to do this talk this morning, and thanks Leena for starting off the talk this morning as well. Hopefully everyone can see my slides now. So in the next 20 to 25 minutes, I'm going to hopefully cover endoscopic management of bariatric surgery complications. And to be honest with all of you, this traditionally, this topic alone would typically take a whole session, meaning at least a half day to a day. So I'm hoping to give you fellows a glimpse of what to expect in managing your patients post-operatively. I have no disclosures. In my main objectives is really to cover the three more common entities that we have patients experience post-operatively, being obstructions, bleeding, and leaks or fistulas after the most common operations being the gastric bypass and the sleeve gastrectomy. And again, my goal is really to go over just some general concepts when it comes to those three topics. Strictures and obstructions can vary in patients post-surgery, and this slide, I think, hopefully demonstrates the various types of strictures that you may encounter in patients post-operatively. Many of them act differently and are intervened in a different manner as well. But in general, endoscopy is used for not only diagnosing, but also treating many of these strictures. And when assessing a stricture, it's really important to understand when they typically would occur in your patients post-operatively. So for bypass patients, it's typically seen within the first month to 3 months after an operation, with the primary complaint being dysphagia, with a progressive dysphagia in your patients. When choosing endoscopy to not only diagnose but more commonly treat a patient that has those clinical manifestations, it's important to understand what tools you have available endoscopically. The most common tool.
For 1 second, we can't see the progression of the slides. We're still on the first slide, so I'm not sure.
In my show, I apologize for that.
Yeah, we are still on the first slide on the title. There we go.
Are you on the 6th slide now, Adrian?
Yes, we are.
Okay, great. So I apologize for that. Let me see. I'm going to go back to my full screen mode. And then I just want to make sure that you're able to see that image before I progress. And this is an image that has about 8 pictures on it. Adrian,
we are seeing that.
Okay, great. I apologize for that.
No worries.
So this slide basically is demonstrating the different type of strictures that you may encounter in a patient, in particular post-gastric bypass. And again, highlighting the differences in the types of strictures from what we call cicatrial strictures, which is demonstrated here in the first one, which is just a mucosal abnormality, to an ischemic stricture or a fibrotic stricture. And again, just highlighting how these may be responding to therapies. Again, strictures typically after gastric bypass occur within the first 1 to 3 months post-surgery. They can occur later, and they typically manifest with dysphagia. When you're talking about tools for treating these patients, the most common tool utilized is probably an endoscopic balloon. And most of these balloons will have the ability to have a wire that can go through the lumen of the balloon. And they come in various graduated sizes, and typically the smaller sizes start in 6 millimeters, and they can go all the way up to 20 millimeters, but typically for most patients, your goal is to minimize an aggressive dilation and typically stay below the 15 millimeter mark.
Bipan, we are still on the slide with the 8 pictures. Is that?
No, apologize again.
Yeah, the full screen is not advancing for some reason.
Okay, so let me just leave it in this screen since we're running into those problems. So I'm going to go ahead and make sure that you can see it at this screen here, Adrian.
Yes.
Okay.
So IT folks, that's a good plan to do that.
Yeah, I'll do that. So when you're talking about dilation techniques and avoiding major complications, as Leena had alluded to, it's really important to make sure you have good patient selection, in particular for airway control and sedation issues. But then again, having the different modalities. Again, as I mentioned before, the most common utilized endoscopic tool is a balloon, either wire-guided or non-wire guided. But there are other modalities available, such as bougies, with and without fluoroscopy. Also, it's important to understand the anatomy and make sure you understand what type of bypass is created. Make sure you avoid inadvertently dilating the cane-to-cane portion of the root limb, and make sure you feel comfortable with your technique. And it's always important to do a stepwise graduated dilation rather than doing an aggressive dilation in these patients. So assist, when you're using a wire or decide to use a wire, how does that help you? It really assists you in directly placing the balloon into the true lumen and not creating a false lumen. It allows you to pass the balloon into the root limb, as well as maintain the endoscope in proximity to the actual stricture itself. When it comes to risk of perforation and how successful are you, it really is more dependent on the pathology and not necessarily the technique itself. So when you talk about anastomotic strictures and educating your patients, typically the perforation rate is less than 1%, and you can see other various perforation risk dependent on the strictures as demonstrated in this slide. Other tools for dilation include these bougies, and what you can see on this slide is the different forms of bougies. You can have the taper tip bougie that's on the left of the slide, and these blunt type of bougies on the right of the slide as well. I typically do not use bougies for most of my dilations unless I have a very long stricture that I'm trying to dilate. Again, the most common is this hydrostatic balloon dilator as depicted here on the right-hand side. It's important to understand that with these different devices, they do act differently, with the bougie allowing you to have both a longitudinal as well as a radial force, and the balloons typically allowing you to have a radial force in dilation. So as Leena had pointed out, understand your anatomy. This is a normal appearance on the left of a gastric bypass with a normal size outlet. And an easy rule of thumb to remember is if your endoscope can traverse the opening, then you typically have a minimal, if any, of a stricture. On the right, you can see a severe stricture with barely any appearance of the lumen itself. So in that patient where you can't see the lumen, it behooves you to have tools available such as a wire, as well as having fluoroscopy to safely and adequately dilate that stricture. I'm going to show a quick video on how to do an endoscopy for a dilation. Again, remembering having adequate sedation in your patient is going to be very important, particularly when you do the dilation. The patients can have significant discomfort. At the time of the dilation, you really want to avoid patients moving significantly so you don't have a potential complication as well. So as you can see in this video, we're essentially getting into the esophagus. We're going down into the esophagus distally. I'm going to speed it up a little bit to the point where it's important. And what you're looking for in this patient typically is going to be areas of abnormality. You're going to look for proximal stasis within the esophagus as well. You're going to look for other concomitant abnormalities such as a marginal ulcer, and those can manifest in patients as well. I mean, they can typically have the same type of symptoms in your patients with dysphagia as well as abdominal pain. If this video doesn't play, we'll go on to the next slide. Here we go. So what I'm looking for here is in this patient, we're able to go through the lumen and into the roux limb. And that definitely gives you an added benefit of avoiding dilating the roux limb, especially the candy cane. It allows you to pass the balloon directly into the roux limb. And as you bring the balloon back into the lumen, you can adequately place the balloon exactly where you want. So here you can see us placing a radial expanding balloon into the site of the narrowing. And having a patient with adequate sedation, we're going to then sequentially dilate up this balloon. And again, a rule of thumb is if you see a stricture that is relatively tight, it's important to do serial dilations on a regular basis rather than one dilation all at one time. So here, as we blow this balloon up, the endoscope can be used as your eye. You can tip your endoscope directly into the balloon and you can see your balloon sitting within the stricture itself. A lot of times you can move the balloon back and forth through the lumen itself, and that can determine how tight the stricture is. It's also very important to communicate with the nurse or the tech that's assisting you and making sure that they don't have inadvertent too much tension. There we are moving the balloon back and forth. This balloon is about 10 millimeters in diameter at this time. There's been a number of publications that have been done in successful management of strictures after a gastric bypass. One of our earlier publications looked at this, and what we found for most patients, one endoscopic session is required in the majority of patients, particularly in patients that have a stricture that is early on post-bypass. The ones that are typically later in months, so greater than that 3-month time frame, may require more serial dilations than just a routine dilation. Management of bleeding is going to be my next topic of the 3. It's important, as surgeons know, having good techniques in managing these from resuscitation and then deciding where is the best place to manage this patient. My rule of thumb is if a patient has a refractory hypotension, if they're failing hemoglobin or they're dropping their hemoglobin despite transfusions, and they have persistent tachycardia, it's important to manage that patient, and typically in an operating room session for most of these patients. Your endoscopic tools for managing patients with bleeding postoperatively typically include thermal therapies, injection therapies, as well as mechanical compression, and those are typically utilizing clips that are readily available. This is an algorithm that I use for my trainees in patients that are post-operative. They may have bleeding. And depending on how they manifest will kind of dictate where your thought process is and where that bleeding may be. And so for the most common operations being the gastric bypass and the sleeve, if you have a patient that has bright red blood per mouth, and they're typically early on in their postoperative time frame, you're typically worried about a staple line bleed. And if this can be at the gastric jejunostomy, or it can be anywhere along the sleeve staple line. If patients are remote from their gastric bypass, I typically are more concerned about a marginal ulcer in these patients. If a patient that manifests with a bright red blood per rectum and they're early on in their postoperative course in a gastric bypass, you can have several areas where you have bleeding manifesting, and this can be from the gastric remnant, it can be from the jejunostomy, as well as from the gastric pouch, but more commonly more distal. And if this is more remote from their bariatric procedure, you can have a marginal ulcer manifest, as well as bleeding from the sites, as I mentioned earlier. So knowing this information will help you decide when to take the patient back, but also where to take them back. My rule of thumb, again, if it's early in the postoperative time frame, it's probably best to take them back into the operating room. At that time, if they have a particular gastric bypass, you can clamp their bowel and avoid having a lot of insufflation of the small intestine when you're doing the endoscopy. I also recommend utilizing CO2 as it quickly dissipates compared to room air. The tools that you can use in the operating room or in the GI suite include these cooperative coagulation catheters. If you have a marginal ulcer with hemorrhage, they provide a compressive factor right at the bleeding point. You can then apply an energy, and most of this energy is very directed right at the vessel itself. And so you have a combined effect of the compression as well as the energy itself. Using probes that allow for irrigation as well as for energy is also very helpful in patients when you have a particular site. My go-to for most of my patients when I have an ulcer that has bleeding is using more of a bipolar device or mechanical compression. And the reason for this is the bipolar device has a limited energy spread. The energy is just between the actual rings as depicted in this image. And with bipolars, because of that less energy spread, you're typically using a much lower voltage, and your risk for having a significant perforation or other lateral spread is much less in patients as well. Having various tools, though, is important. Injection therapy is also commonly used, and this is very helpful when it's difficult to appreciate the exact site of the bleeding, because when you inject an agent, you're basically trying to cause a compression around a particular vessel. So, for example, if you have a patient where you see a visible vessel as depicted in this picture, in the middle of that you see a visible vessel, you can use the injection needle and surround this area and inject an agent. And this can be typically saline, or you can use epinephrine within the agent itself to cause both a hemostatic effect from compression, but also from the agent itself. And at that time, you can use a mechanical compression, such as a clip. These clips are readily available that can go through the working channel of your endoscope. And the pros of this is allows for vessel control as well as for a mucosal reapproximation, with the added benefit of not having an energy source that can potentially lead to a perforation. There are also available devices called these hemosprays. These are relatively new to the market. It's an inorganic powder that is sprayed within the lumen itself. It has a compressed gas that allows a widespread use, and the powder itself absorbs water and blood, and it forms a gel-like material and is allowing the area to coagulate. There are publications out there for how do you treat marginal ulcers, in particular bleeding ones. And the things that we've learned for most of these patients is look for the etiology of these. And the most common etiologies, at least in most publications and ours as well, are non-steroidal usage, as well as tobacco uses as the most common manifestations for most of these patients. Ulcers can have bleeding, but more commonly they typically manifest with pain. And again, most ulcers, unlike strictures, are typically seen greater than 3 months post-operatively. But as alluded earlier, it's always important to look for other abnormalities that can lead to these bleeding sources, not just NSAIDs, tobacco, and alcohol. Early ulcers that bleed can be from ischemia. You can also see fistulas, as well as foreign bodies as depicted in this picture as well. So look for all the particular etiologies, try to eliminate those as best you can prior to treating them. So the management for most bleeding ulcers is to look for an underlying etiology, use cytoprotective therapies such as sucralfate. Using proton pump inhibitors is very helpful. But remember, it's important to use these PPIs that can be opened in a capsule form or that are rapidly absorbed, such as a sublingual form. Testing for H. pylori is also beneficial, but typically it's best done using a stool antigen or another form than biopsying. And again, look for the endoscopic foreign bodies that can help as well. My last topic that I wanted to cover was leaks and how do you manage these leaks endoscopically. This is commonly now done using various methods, including radiologic, endoscopic, as well as surgical. But if you look at endoscopic therapies, it's important to understand what type of leak you're dealing with. Is it contained or is it not? How well controlled is it? Is it also ischemia present? And then more importantly, in particular with sleeves, is there a distal obstruction that can be causing the leak to persist? So for endoscopy, what is the principles in managing these problems? I think identifying the site of the leak, understanding how to adequately resuscitate the patient, try to decontaminate and prevent overall sepsis, and then trying to establish some GI continuity is going to be very helpful, as well as providing nutritional support so healing can occur. Small leaks can be typically managed with some of these clips. Unlike the hemostatic clips, there are larger clips available. You can use suturing devices as the endoscopic Apollo device. You can also use stents to help with diversion. Larger leaks, though, typically require more aggressive management. These can typically be diverted with stents, but also can be used or managed with endovacuum therapy or internal catheters. So if you think of endoscopic therapy, the most common therapies utilized are stents, clips, endoscopic suturing, what we call internal pigtail drainage, as well as endovacuum therapy. Stents are, again, commonly used, probably less commonly used today, but still part of our armamentarium. There's various stents that are available on the market. What's important to remember are these stents are typically metal in nature. They typically will have some form of covering around them. The partially covered stents have a tendency to have increased tissue ingrowth, while the fully covered stents have less tissue ingrowth, but have a higher migration rate. The salivary stent, as you can see depicted here, is less commonly used in patients that have a leak or an obstruction, but these typically have the least amount of overall tissue ingrowth. So what are the pros of stent placement? I would say the most benefit for stent placement is really to allow us a diversion of salivary contents. In this endoscopic image here, this is a patient that had a gastric bypass that suffered a leak. It was a revision patient, so a drain had been placed at the time of the operation. And on the endoscopy there, you can see the drain is now eroding into the lumen of the GI tract. So it's important that you pull back the actual drain that is eroded into the lumen. And to deploying a stent, and here we use a metallic partially covered stent that's placed across the area of the dehiscence. This again allows for diversion of salivary flow directly into the stent itself, bypassing the area of leakage. It's important when you do place a stent that you're able to have stent surveillance, so you try to mitigate some of the complications such as a migration of these devices. Endoscopic clips are readily available. These are just some of the commercially available ones as depicted here. These are less commonly used when it comes to leak management because there are other devices that are over the scope clips that are more robust in capturing perforations. These devices can sit on the top of the endoscope. We typically refer to them like the bear claw. These devices, again, will stay on the area of the dehiscence for a much longer time than a typical hemostatic clip. The pros to these are, again, that they're easy to place. You get an immediate sealing. Some of the cons of these are they are a bulky device because they sit on the end of the endoscope, so you have to be very accurate in its placement. And it does require a little bit more of a technical expertise, but something that's easily done for most patients. In this video, you can see a patient that had previously a gastric plication that manifested with a large leak. Here, the endoscope is able to visualize what we think is the actual hole where in the sleeve itself. Some of the principles that we use to help delineate where that is fluoroscopy. We also try to denude or remove some epithelial type cells. And then using this over the scope clip allows us to seal that area. You do need to have healthy tissue in order to capture the area. And you can see this patient is intubated in the operating room setting. The device is somewhat bulky in its nature. Using suction to basically reapproximate the mucosa, we're now trying to place the clip over their site of the perforation. One of the things that I've learned over time is sometimes it is difficult because of the loss of the view with the device itself in accurate placement of the clip. So going back in to see what our success is, you can see I was off by at least a centimeter. The actual opening is to the left of that initially placed clip. Now, as we place the second clip and place suction, you'll see a change in the screen from pus coming back into the lumen itself. Now we have a much better accurate placement of this clip that now seals that perforation. The last couple of topics that I wanted to cover was endoscopic management of these chronic abscesses, and these are seen more commonly after sleeve gastrectomy. These are abscesses that the body has walled off, and it's important to remember the concept is trying to allow for internal drainage of the abscess cavity back into the lumen itself. In this diagram here, what we're showing is an abscess cavity along the upper part of the sleeve close to the angle of His. Using an endoscopic tool with a needle knife, we're essentially cutting the common channel between the abscess cavity and the lumen, allowing for internal drainage of the cavity back into the lumen itself. This obviously requires a more significant amount of technical skill, but something that's readily done. It is important when you have a sleeve leak that you assess for any type of a functional or mechanical obstruction, particularly at the incisura. Here, using a pneumatic balloon, unlike a radial expanding balloon, we're dilating the incisura itself. You can see a rendition of what it looks like on a CT scan with a functional twist. And then using both an internal pigtail catheter as well as a septotomy, we're allowing to drain back into the lumen itself. So for a lot of drainages, we use these pigtail catheters as depicted here. These internal pigtail catheters are ideal when the cavity is relatively small, and they can be left in for a much longer time than the stents that you saw earlier. So these allow for drainage, while a stent allows for diversion. When it comes to doing a septotomy, using a needle knife, which is readily available, allows one to basically drain the cavity back into the lumen. And I'll try to show this quick video on how do you use a needle knife, in particular for either a stricture or mechanical obstruction. In this patient here, you have a mechanical obstruction that led to a leak. And you can see here the endoscope can barely pass through the lumen itself. And we're using this device with an energy source to cut the common septum between the abscess cavity on the left and the true lumen on the right. I'm going to speed up the video a little bit as well. Here we can see that common septum now being opened up. Again, this does require a little bit more technical skill set, but something that hopefully during fellowship you'll be able to see and appreciate. Now that we're opening up this septum, we're allowing for easier drainage of both the false and the true lumen. And the last thing I wanted to cover are these vacuum therapies that have been utilized for leaks as well. Unfortunately, in the US, there is no readily available kit that can allow you to use vacuum therapies just as you would for patients that have a wound on the abdominal wall. These are ideal for larger chronic leaks with large cavities. And what you're trying to do is you're trying to place this sponge either intraluminal or intracavitary to allow for faster healing and closure. So in this therapy here, you can see a NG tube that's placed into the lumen itself with a sponge on the end of it. And this is what's called an intraluminal placement of a sponge that allows you to allow internal drainage and healing. If you have a larger defect in the lumen itself, and this is particularly used for patients that may have a sleeve leak, typically at the angle of His, you can place this sponge directly into the cavity. This does require a fair amount of endoscopic management. Most of these patients require multiple therapies before you can see a success in these patients. But again, this is another type of therapy for chronic abscess leaks in patients. The last video that I want to show in my last slide is just thinking about combining all these types of therapies. Endoscopic techniques in the management of esophageal is using multiple different techniques in combination in a patient that had an unfortunate, devastating leak at the esophageal jejunal area. And I'm just going to highlight just a couple of those therapies using in combination. Here you can see a CAT scan that just demonstrates a large abscess cavity in the posterior mediastinum. This is the endoscopic appearance of that abscess cavity with a surgical drain in place. And unfortunately, the anastomosis has fallen quite a bit farther away from the proximal anastomosis with a large posterior mediastinal cavity. So in this patient, early on therapy is resuscitation, as we all know, managing them with antibiotics. We decided to do evac therapy on this patient early on just because of the size of the defect itself. Here again are your tools typically utilized. This can be placed more commonly through the NG tube. We chose a different route through the cervical esophagus, but essentially what we're doing is placing this large sponge into the cavity itself. So this is an intracavitary sponge placement. Again, this does have to be changed on a regular basis, typically every 1 to 2 weeks. And then once that area starts to have manifestations of healing, you can then plan on putting a stent for diversion as well as external drainage. And this patient eventually did well. The cavity was able to be collapsed. The stent was able to allow for diversion, and the patient was able to have continuity of their GI tract. And this is kind of what it looked like towards the end of the therapy. So there are various therapies that are available. I think endoscopy should be a part of your practice. There are other ways of learning this. ASMBS has a program called Be Safe. It's important to utilize all the tools that are available for you. And most surgical complications can be handled with endoscopic tools and techniques. Thank you very much.
Thank you, Leena and Bipan. Outstanding presentations once again, and exceeding all expectations. Thank you so much. I'm going to turn it over to my co-moderator, Dr. Kunoor Jain-Spangler, who's going to discuss some questions that have been posed. Kunoor, take it from here.
Thank you. And I couldn't agree more. Thank you both so much. Those talks were both so relevant and so educational. And I think they cover a great portion of our didactic curriculum that we're trying to get into our fellows education. So thank you again. We do have a few questions on the Q&A that I would like to, it looks like Dr. Khaitan has answered some of them online. I know we have some call-in listeners, so I'll just review them quickly. First, Dr. Uma Kannan out of Mount Sinai how to decide if the pouch is dilated or normal size, any size criteria. Dr. Khaitan responded, should be about 5 centimeters long and 2 to 3 scope diameters wide. I think we pretty much all agree on those criteria. Another question from Dr. Marina Chumakova-Oren out of Duke University. I have a difficult time wrapping my head around using the Aspire Assist for weight loss. Seems like there are a lot of similarities with essentially bulimic behavior, but via a G-tube in this case. Do patients have success long-term for this? Does it modify their eating habits for sustained weight loss? I think this is a great question. So Dr. Khaitan, I'll let you elaborate a little bit on your online answer. You are still muted though.
Now can you hear me?
Yes.
Yes. Thank you. But yeah, aspiration therapy, I have to say, I mean, it definitely has an ick factor to it. And if you, like Stephen Colbert, look up his presentation on it on YouTube, it's quite entertaining.
Yes.
But once you get past that and you look at their data, I mean, we're all scientists, right? And we have to believe the data. And the patients do have pretty reasonable weight loss. There's really few side effects. It doesn't preclude further therapy. And it really does involve intensive counseling so that it's not that the patients can eat, you know, a whole pizza and then it's just going to empty out the tube. All those carbs, that bread, none of that is going to come through the tube and it will be ineffective. So patients actually do have to learn mindful eating. Proteins and vegetables are what can come through the tube if they're chewed well. So the patients have to learn to eat slowly, chew their food and not swallow it whole, you know. And so I think it's really a technology that belongs in our armamentarium, and it's something that we're using, and I have had some patient interest. So it's, you know, I think there's a lot more to learn about it, but it's everybody loses weight in different ways. So it's great that we as providers can give patients every way to possibly do that.
Great, thank you.
Just as a quick follow-up to that, Leena, can you elaborate a little bit about, you know, traditionally decades ago talked about restriction and malabsorption, and we're getting further and further away, understanding that that's not really the mechanisms by which a lot of the bariatric and metabolic procedures work. Can you elaborate a little bit on the metabolic impact of such therapy, or even of the balloon therapy, if any?
I'm going to tell you that I'm not well versed on the metabolic impact of those. Maybe Bipan has some more thoughts on that, but we definitely, you know that we are metabolic surgeons, and restrictive and malabsorptive, as you said, is not all of it. It's definitely a component, but there are also hormonal effects. But I couldn't tell you the specifics with those particular therapies.
Yeah, I think, Leena, you're absolutely right. I think, you know, we're just starting to learn a little bit more about these endoscopic primary therapies as far as what type of neurohormonal effects they have. But very similar to our bariatric operations, if you look at most of the studies that are being done on these devices, they are having the same impact. They may not be as great as what we see in our surgical interventions, but, you know, the same response that we expect in ghrelin in both the sleeve, both the surgical sleeve and the endoscopic gastroplasty is similar. I think the ablative therapies as well as the barrier therapies are probably more interesting because those have the same foregut theory, where there are some hormonal responses that we may not truly understand right now, but those are being altered with these barrier type therapies as well as these ablative therapies in the duodenum.
Thank you. Dr. Chan, we have a couple questions on stenting from my fellows here at Duke. Dr. Chumakova-Oren is asking, what are some of the criteria you use in order to decide whether you're going to stent versus reoperate on a leak? And then Dr. Yenyi Juo is asking, is there any role for covered stents in patients with refractory marginal ulcers?
Yeah, so I'll tackle the first question. You know, I think it's still important to look at your patient and see how clinically ill they are or not. I think if you have a patient that has peritonitis, they have severe tachycardia, hypotension, all of those things, I think that may be a patient that's better served being in an operating room, and then you making a decision if you can manage it with an endoscopic stent. But for most of those type of patients, it's probably better that you do a surgical intervention, and most of those can be managed laparoscopically as well. So I would say that if you have a patient that doesn't have severe sepsis and they may have either a abscess cavity that is seen on imaging, or you're not certain what they have, the endoscopy is a good diagnostic tool. And those patients, I typically would utilize an operating room environment for those patients. I would inject contrast for those patients. And if it's localized in the left upper quadrant and in a contained type of an environment, then I think your endoscopic therapies can go a long way. I would tell you my rule of thumb now is using less and less of those stents for patients, using more of the internal pigtail catheters where you can allow for internal drainage for patients. And the biggest reason is they're better tolerated in patients, and they really allow for what you want, which is sepsis control. I always think of a stent as using it for purely diversion. That's what a stent does. It diverts flow, but it doesn't necessarily allow for sepsis control. If you have something that is relatively small and you think antibiotics and diversion will work, I think that's reasonable for most of those patients. So when I think of a leak, I always think of all the different tools I have available, and stents are just one of those. But not definitive. I think the second question, again, refresh my memory, was the second question about?
Refractory marginal ulcer and use of stenting.
So I think for a refractory ulcer, stents, again, are very uncomfortable for patients if you use them for a long time. Stents can also have the risk of causing an erosion. So if you already have a weakened lumen because of a mucosal ulcer, you're probably not best using a stent. So that, in my mind, is having a patient that has both a concomitant stricture and an ulcer. And for those patients, there are studies out there that look at using the suturing devices to cover the actual mucosal defects. So for most patients, I would say I would use cytoprotective therapy for them. That's probably the most important thing. Looking to see if they have an offending agent, which you haven't been able to find. I would say tobacco and non-steroidals are the most common ones that we see. Don't be afraid to use urine nicotine on your patients just to confirm that. Don't be afraid to use platelet aggregating studies just to confirm that they're not on NSAIDs. Eliminate that. And if they do not heal with conservative therapy, then you may have a patient that's better suited with having a resection of that area rather than doing endoscopic therapies. So mucosal covering with the suturing devices have been done. I've done that in my patients. It's very cumbersome and hard to do. It does introduce a foreign body, so it's sometimes counterintuitive to use that, but I would go more towards surgical resection and revision.
Thank you. We have one more question. I will just repeat from earlier that this will be archived on the ASMBS webinar website. I do know a lot of people have other Zoom meetings to get to, so we'll continue, but if you want to check it out later, you can. I believe this probably should go to Dr. Khaitan. One of the concerns with temporary therapies such as balloons is that they are just that, temporary, and patients may lose any benefit gained in the short term. Any behavioral tools in this setting are there any that have been shown to be more effective in sustaining the benefit gained?
Yeah, so actually, these procedures are tools, and they will not work without concurrent behavioral therapy. So they do need ongoing support, both psychologically and from a dietary standpoint, and that is a key component to the success of any weight loss procedure, let alone just these primary endoscopic procedures. So there has been alteration of change or altered behaviors that is sustainable, and that's what the patients are taught, that you're going to have the balloon for the first 6 months, but we're going to continue the intensive therapy for the 6 months after it's out, so that hopefully everything you learned, the amount of food that you can live on, is sustained once the balloon's out. And the hope is that, that after doing this for a year, that these behavioral changes become habits. And really, the patients need ongoing support. And I would say that that's true for any procedure. It was interesting, the endobariatric trial, when they were trying to see the effects of it in their multi-center trial, they actually designed it without any behavioral support. And I think that that was one of the failures of that, because they just wanted to see the isolated effect on hemoglobin A1C and diabetes with the barrier itself, with nothing else changing. And so, they would have shown much more efficacy had they done both. And even I was involved in the TOGA trial, and the behavioral counseling was variable. This was a transoral gastroplasty. And again, the failure of that device was, the technology was wonderful, but the failure of the device was that the counseling was variable. And so for any of these procedures to show efficacy and to remain on the market, they need accompanying behavioral alteration and therapy.
Absolutely. Well, thank you both again so much. We really appreciate your time and your expertise. I hope everybody has a great Friday.
Thank you guys so much. So great to see you all.
Bipan, Leena, thank you once again, and we look forward to seeing everybody next month.
Thanks again.
All right. Well, thank you, Dr. Khaitan and Dr. Chen. That was fantastic. We'll take a couple questions from the viewers, and we don't have a whole lot of time, but I think we have time for a few questions. Dr. Chen, do we have some questions coming in?
Yeah, so again, thank you for sharing, everyone. The experience and the videos were fantastic. In regards to when you do choose to do a diversion, I think this question is for Dr. Chen. What's the time frame for stent surveillance?
Yeah, that's a great question. I think it really depends on what type of stent you utilize first. I think if you're utilizing a fully covered stent where you have a much higher risk of stent migration, you're probably going to want to be doing x-rays on a regular basis. For my practice, my tendency is to use a partially covered stent just because I like to get some tissue ingrowth approximately. But a fully covered stent, I would say at least one x-ray every 1 to 2 weeks is probably important. When you put that stent in place, make sure you put it a little bit more proximal, because these stents are relatively long. They'll migrate slowly over time. So if you allow it to sit more higher up, you can try to help minimize that migration. You can also use clips to help hold the stent proximally, or sutures to help hold the stent proximally. So there are different ways to kind of mitigate some of that risk for migration. The partially covered stents, because of that tissue ingrowth, you can leave them in longer, but I probably would try to avoid leaving them longer than 4 weeks, or they become very difficult to remove.
Never fun having to pull those out when they're really in there. Should all leaks get endoscopies? And what is the healing rate from only external draining? External drainage.
Yeah, that's a great question. I think if you have a patient that has a low pressure system, so a gastric bypass, I consider a low pressure system. In most of those patients, I think you have a much higher chance of successfully manage that patient just with sepsis control. So that may be an external catheter that's placed either surgically or radiologically, and you may not even need a stent in place. I think for sleeves that have a really high pressure system, those I think for the most part, you have to make sure that either there's no distal obstruction at the incisura, try to make sure that the pylorus is widely open, make sure there's no, I would say, sleeve configuration that's not optimal. If you have that, I think in reality, those patients probably will be better treated with either the internal pigtail catheters, which is my preference for most patients. If you can't do an internal pigtail catheter because you can't find the hole, I have a tendency to avoid a lot of external catheters, radiologic ones, because a lot of times then they become a persistent gastrocutaneous fistula. So I'll try to do a stent in that patient. So I think low pressure systems like a bypass, a lot of times just doing an external drainage works very well. In my experience, sleeve leaks don't do very well just with an external catheter. So I try to avoid that because I think that becomes a persistent fistula. A lot of times you'll see these fistulas go up into the lung, into the pleural space. So trying to internally drain them or divert them is probably the best.
Great. Dr. Khaitan, as I understand from your talk, you do intraoperative endoscopy on all bypasses and sleeves?
Correct.
Just two quick questions. Who's doing the endoscopy in your cases? Are you scrubbing out and doing them? Do you have a resident doing them, a partner, a fellow?
Myself and my fellow. One of us will scrub out and do the scope and then scrub back in.
Okay. And then about the leak tests, there have been a couple studies that have come out specifically for sleeve. One multi-center study that we actually did, and then an MBS QUIP showing really no benefit of leak test in sleeve, and in fact higher leak rates in the patients that got a leak test. Of course, that's confounded. Just wondering about your thoughts on the sleeve leak test and the utility of it.
Yeah, I think that the leak part of it, honestly, is probably less of the reason I like to do the scopes then, but more so looking for any kind of bleeding, because if my distension with my endoscope can cause some staple line bleeding, then when they start drinking can cause staple line bleeding. So I may as well just do that stimulation and take care of it then. And also, it gives me a degree of comfort also to look at my sleeve configuration and the anatomy of when I'm looking at it, so that I can anticipate problems or confirm that the morphology of the sleeve is the way I want it to look. So, I haven't found a leak in years, on a sleeve, but it does help me to sleep a little bit better. But I think the leak is less the reason, and the other reasons I stated more for me in a sleeve.
I also would scope all my bypasses, and I agree. Sometimes even like a little clot there can sometimes cause a lot of dysphagia, retching. And so just to make sure that the scope goes through and clear any clot, even if it's not actively bleeding, I think absolutely makes a difference. I was curious from a question from this morning, chronic marginal ulcers, non-bleeding, and the role for stent in that scenario. How does that work? What's the mechanism behind that?
Yeah, so I think that I was asked that question earlier. I don't think stents are really a good use in marginal ulcers. I think the stents themselves, because of the radial force that they have, they can truly lead to a potential full thickness perforation. So I think stents probably are not usually used for that, but I think if you can try to get mucosal coverage or apposition, that's probably going to be more helpful. So suturing has been done for some of these marginal ulcers. The problem with suturing the chronic ulcers is because of the friability and the fibrosis of most of the chronic ulcers, it's hard to get the mucosa to cover an ulcer. So what I do for most marginal ulcers, after eliminating any of the potential causes of that ulcer, I like to make sure there's no foreign body there, staples, sutures, those types of things. I think for some of those patients, once they are truly chronic in nature, you're probably better off doing some form of surgical resection of those. I think that's what they're going to require. But if you're trying to identify them early, I think really helps trying to do cytoprotective therapy. In my experience, cytoprotective therapy is more beneficial than using a proton pump inhibitor. PPIs can help, and those are really those large gastric pouches where they have some parietal cell mass left. But I think you have to make sure you open the PPI in a capsule form or do a sublingual form of it. Trying to do the other forms are not effective. So stenting, I don't think is a great idea. I think trying to cover it is the best.
There was another question. Are you using steroid injection as an adjunct to your stricture dilation? You showed the balloon dilation.
Yeah, I think that's a very good technique. My rule of thumb for most of these, again, if they're the true circatrial or the early strictures that you see, probably just one-time dilation is probably successful in 80% of your patients. But if you think you have a patient that's going to require more than one session, my rule of thumb is bring them back early. Don't wait too long. probably have a interval schedule of every 2 weeks, and probably do that for at least 3 sessions. And my rule of thumb is 3 sessions. If after that 3rd session I still see that they're improving, but they're not where I want them to be, that's when I do the steroid injection. If it's a stricture that is truly fibrotic and I can tell based on how it feels, how it looks, those are the ones that I'd go right to a septotomy with a needle knife. So I think the fibrotic strictures that are probably more than that 3 to 6 month time frame, those are probably better served with going to a septotomy much earlier on. Septotomy, balloon dilation in the same setting, and then probably doing steroids in that same setting as well.
And how about you, Dr. Khaitan? Same approach or similar?
Yeah, pretty much the same thing. I don't use steroids up front. Usually at the 3rd dilation would be when I would start looking at that, because usually the other interventions are going to help more. And then if you have a really difficult stricture, that's where you're like, okay, maybe some steroids will help here too.
And are there any strictures, and this is for either of you, are there any that you just look at endoscopically or imaging and you say, I'm not even going to try dilation, this just needs a revision, and go right to surgery? Or will you try and dilate every stricture?
For the most part, I think I'm going to try to dilate it, unless there's some underlying pathology that I know that is puts me at a high risk of a perforation while I'm dilating. But for the most part, I think you can dilate most of them and then treat the underlying pathology.
Yeah, I would agree with that. I mean, the only ones that I am a little bit more aggressive, I would say, are the ones that come to me that have already undergone previous dilations by another provider. But I will always try at least once. But, there are times when you have a patient that has undergone multiple dilations. They're more than a year out from their index operation. And you scope them yourself and you can feel this fibrotic type of an ulcer. And those are, in my experience, have been those ischemic ulcers, the ones that really manifested very early on, and they never are going to get better. And they typically will have a concomitant ulcer as well. So they're a concomitant ischemic ulcerated area that over time has just not gotten better. And if they've gone previous dilations, I'll still take a look at it myself. But after one attempt, if I can tell it's not going to be successful, I will go to an operative intervention.
Okay, any more questions, Judy?
Nothing on the board. Last call, friends.
All right, well, those were 2 great talks, and we actually ran over for questions and answers, but that's fine. Everybody learned a lot. I really want to thank both of you for participating in this inaugural fellow lecture series. We appreciate it. The recording will be available on the website for anybody who missed and wants to watch it or wants to watch it again. And so again, thank you to both of you, and thank you to Judy Chen for co-moderating.
Thank you guys so much. Appreciate the invite. Great job.
Thank you so much.
Thanks. Bye-bye.